approval. I've always considered it appropriate to either approve or disapprove of every person, place, thing, and situation in my life. However, the Serenity Prayer, which places great emphasis on acceptance, doesn't even mention approval. The reason? We live in two worlds. In God's world, approval has nothing to do with acceptance. In the real world, it does. If you don't like merchandise, don't buy it. If purchased and unsatisfactory, take it back. In assertion training class, they tell you, don't be obnoxious, but don't be a wimp either. Don't accept merchandise and service that doesn't meet with your approval. In the spiritual world, the psychological world, the world between our ears, the only world where happiness can be found, approval isn't even a consideration. I can't imagine one of God's messengers rushing up to God saying, "We've got a big problem, God. Paul doesn't like the day we sent him." I get a picture of God thinking of another place I can go if I don't like the way he's running things. Approval, a requirement for acceptance in the outer world, is actually an impediment to acceptance in the inner world. Life doesn't seek our approval. It insists we accept life on its terms and doesn't care whether or not we approve. Our challenge is to be emotionally comfortable regardless. Situations often change after we accept them. They never change simply because we're unhappy. Acceptance. At an AA meeting, I once quoted another AA member as having said, "Life is not painful. It's our resistance to life that is painful." Afterward, a young woman strongly disagreed. She said her 13-year-old son had had a motorcycle accident while drinking. He'll be a paraplegic for the rest of his life. I certainly can't accept that. We talked a while about the difference between acceptance and approval. Sometime later, she looked like an entirely different person. She had accepted the challenge life offered her and had turned her massive resentment from destructive anger into constructive action. Attitudes being contagious, her son had adopted her new approach to life, and they were both busy sharing, caring, and working with other paraplegics. Typical of the AA way of life, they had turned a strong negative into a strong positive. They moved from victim to hero, from living in the problem to living in the answer. They picked up the challenge of paraplegia the way AA members pick up the challenge of alcoholism. Acceptance has at least two deficiencies. It has no duration, and it's not transferable. I often hear people say, "I turn my will and life over to God in the morning, but take it back as soon as I get to work." I doubt if that's literally true. They didn't change their mind about accepting God's will. Instead, the acceptance they felt so sincerely in the morning applied only to life at that moment. Life then exercised its right to change the situation without notice. The situation giving them trouble now is not what they accepted in the morning. Acceptance doesn't carry over. It has to be repeated over and over and over again with every new situation and circumstance. Acceptance isn't a destination. It's a continuous process, a journey, a philosophy, a way of life. Failure to recognize this can result in all sorts of problems, including a return to drinking. Once we accept our powerlessness over alcohol, we ask for help and we get sober. After a period of time, some of us forget to continually renew our acceptance of our powerlessness, and we end up drinking again. Acceptance isn't predetermination, passivity, quitting, or acquiescing. It's the opposite. It's picking up the lance and facing life's challenges bravely. It's being a hero, not a victim, active, not passive, winner, not whiner. Acceptance is getting on with life, not sitting back whining, complaining, blaming, resenting, justifying, or fault-finding. It's not all those things that seem so natural and normal, but which only make matters worse for oneself and for everyone else. It also seems quite normal to ask the question, why? Like approval, why is more than appropriate in the material world, but it is definitely an impediment to acceptance and to emotional sobriety. I once heard Reverend Robert Schuller on TV express the opinion that when people ask God why, they don't want an explanation, they want an argument. What's the difference between acceptance and surrender? As I see it, surrender comes first. We give up. We stop doing whatever we've been doing that isn't working. Then we relax. Easy does it. Let go and let God. While relaxing, we look around to see what we can do to make a success of our lives in spite of the current circumstances. We decide to change our attitude to one of acceptance. Acceptance isn't a closed fist angrily holding on to what it wants. It's an open hand that has dropped what it was holding and is now ready to receive whatever life has to offer. Dr. Viktor Frankl, the Jewish psychiatrist mentioned earlier who survived the Nazi concentration camps, in talking about the ultimate meaning of suffering, speculated that the highest level a person can achieve in life is to survive with dignity and courage a difficult fate, and then to teach others how to do it. When terrible suffering is borne with dignity and courage, he said, when you take your cross upon yourself with courage, you not only squeeze out the meaning to such a terrible event, but you reach even the highest possible level of meaning. Upon hearing this statement, I thought how appropriately it could be applied to the members of Alcoholics Anonymous and the other anonymous programs. During my first 7 months in AA, and even though I didn't really believe it, I admitted I was an alcoholic. Then on July 31st, 1967, I accepted the fact that, even though I had no choice in the matter, I was, perhaps as a result of a cosmic mistake, a mild sort of alcoholic. At that moment, my life changed dramatically, and it has gotten progressively better ever since. If my life were pictured on a graph stretching from left to right, the curve would be downhill, my life deteriorating, until the day I accepted my alcoholism. Not a straight line down, there were ups and downs with enough ups to keep me from recognizing the chronic downward trend. The curve would continue its up and down swings, but with a pronounced upward slant beginning immediately after my sobriety date, and continuing until today, and presumably on into the future. For me, both alcoholism and sobriety have been progressive conditions. Alcoholism progressively downward, sobriety progressively upward. What happened on my sobriety date to cause such a momentous change? What did I actually accept when I accepted my alcoholism? Apparently, I accepted the challenge of living life successfully in spite of the fact that I can't drink like other people. As a result, on that date, I moved from living in the problem to living in the answer. I moved from the role of victim to the role of hero in my own life story. I moved from a life of hopeless inactivity to a life with more to do than I can possibly accomplish in one lifetime. I moved from whiner to winner. Above all, I moved from being just another drunk to being a sober member of Alcoholics Anonymous. At every moment of every day, life asks each one of us, which role do you want to play in your life story today? The play goes on regardless, but you have a choice. Do you wish to be the victim or the hero? The choice is yours. As I see it, the graph of my life will continue upward as long as I continue to do the things that have brought me this far. I want all I can get of this way of life, and I'm limited only by how long I can stay here. Therefore, I'm going to stay around as long as I can, and with ever-increasing enthusiasm, I'm going to continue to do everything that has been working for me. Addendum A. Medicating safely. Medicating. My point of view. When I was 4 years old, my father purchased a house drugstore combination, and I grew up in an atmosphere of better living through chemistry. This environment said no matter what's wrong with you, there's something you can buy that will make you well, or will make you not care that you aren't getting well. To further my knowledge along these lines, I went to pharmacy school and medical school, and then specialized in internal medicine. For 28 years, I practiced medicine as a certified diagnostician, with a special emphasis on the use of prescription medications to treat the medical problems of adult men and women. At the height of my career, after being forced, against my better judgment, to attend meetings of Alcoholics Anonymous, I recognized my addiction to both alcohol and my own medications. Not only had I missed the diagnosis, so had a neurologist, 5 psychiatrists, a medical social worker, and several priests. Even the Mayo Clinic didn't know what was wrong with me until Max, my wife, betrayed me by telling them about my nocturnal drinking and pill-taking. Now, after closely associating with and treating alcoholics for over 25 years, I have certain opinions regarding the relative safety of mind and mood-affecting medications. These I share as opinions, not as advice. I have no opinion on the newer antidepressants and tranquilizers, which came along after I left practice and which are said to be non-habituating. But I recall hearing the same thing about the old ones when they first came on the market. All through my medical career, and now in AA, I repeatedly hear people say that alcoholism results from an inability to handle life's emotional problems. In retrospect, I wonder if I didn't first learn the real cause of alcoholism back in the 1930s in pharmacy school. At that time, one of my favorite books was Goodman and Gilman's textbook of pharmacology and therapeutics. I don't recall the year of publication, but under diseases caused by alcohol, the authors listed a medical condition called pathologic reaction to alcohol. They described this as a disease wherein the patient displays grossly abnormal, unusual, and inappropriate behavior after the ingestion of only a relatively small amount of alcohol. They said the condition was uncommon. But today I wonder, could doctors Goodman and Gilman, without realizing it, have been describing the root cause of alcoholism? Still today, the American Psychiatric Association recognizes an abnormal reaction to alcohol. They describe alcohol idiosyncratic intoxication as, quote, maladaptive behavioral changes, for example, aggressive or assaultive behavior, occurring within minutes of ingesting an amount of alcohol insufficient to induce intoxication in most people. The behavior is atypical of the person when not drinking. Prevalence, apparently uncommon, end quote. Uncommon? Again, I wonder. Their description of idiosyncratic intoxication sounds like the drinking history of some of the alcoholics I know. Might not the war stories heard in AA be variations on this theme of an abnormal reaction to alcohol? While it seems obvious that alcoholics drink for psychological reasons, being obvious doesn't make something true. Otherwise, the world would be flat and the sun would revolve around the earth. I think alcoholics drink for all the same reasons anyone else drinks. To relax, for instance. But that alone isn't alcoholism. That isn't what makes alcoholics drink. Alcoholics drink because they have to, because they react differently to alcohol. Alcohol doesn't quench an alcoholic's thirst. It makes them thirsty. And they end up drinking too much one more time. the opposing view. Psychiatry is a branch of medicine, and professionals in the field of medicine generally accept the psychiatric opinion that alcoholism is a symptom of an underlying psychiatric problem. Tell a physician you're an alcoholic and, rather than withholding tranquilizers as he should, he may interpret your statement to mean that you have a sensitive nature and need more sedation than the average patient. Doctors prescribe pills all day long. Why should they consider a self-proclaimed alcoholic any different from any other patient, aside from the fact that alcoholics are, to the doctor's way of thinking, addiction-prone, or have a so-called alcoholic personality, or a chemical imbalance? Psychiatrists specialize in talking, in listening, and in psychopharmacology, the use of mind-affecting prescription drugs to treat mental and emotional illnesses. Even when doing psychotherapy, they commonly prescribe drugs to help patients relax and feel better while talking. Indeed, some psychiatrists write more prescriptions than physicians in any other branch of medicine. It doesn't usually occur to physicians to change their prescribing habits when prescribing for an alcoholic. They don't ordinarily think of alcoholics as reacting differently to drugs than do non-alcoholics. In the minds of most psychiatrists, and perhaps most physicians, alcoholism is still a psychiatric symptom, a symptom that demands treatment with mind-affecting drugs. However, because these drugs act on the brain in a manner similar to alcohol, alcoholics often react abnormally to them. They become dependent on the drug, or they return to drinking, or they become dependent on the drug and return to drinking. These medications should be prescribed for recovering alcoholics only after considerable hesitation, and only in the absence of adequate non-chemical alternatives. Even when doctors are concerned about prescribing an addictive medication to an alcoholic, they believe they can prevent addiction by monitoring the number of prescription refills. They think they can prevent addiction by refusing further refills after they notice that the patient is abusing the medication. Abuse, to a doctor, means taking more pills than prescribed. The cause of abuse is thought to reside in the so-called addiction-prone patient, not in the pill. The idea of the patient being the victim of an abnormal response to the pill, as he or she is to alcohol, is seldom considered. Nor is it generally recognized that by the time the patient is found to be abusing the pills, the disease is already active and needs treatment, not prevention. How this affects you. The topic of prescription pills provokes controversy among alcoholics. Those who should continue their medication often look for excuses to stop. Others use the discussion to rationalize their continued use. Those who need an antipsychotic medication such as Haldol, Stelazine, or Mellaril are far better off staying sober on the medication than they would be by refusing to take it, losing contact with reality, and getting drunk. Likewise, suicidally depressed alcoholics are better off staying sober on an antidepressant than stopping drinking by killing themselves. Furthermore, manic depressive alcoholics staying sober on lithium are preferable to those who get drunk at the top of the highs or the bottom of the lows of the true manic depressive illness. Most situations are not this clear-cut. While a disaster may result if an alcoholic ill-advisedly discontinues a needed medication, many recoveries are spoiled by the use of seemingly innocent prescription medications. If you've ever wondered if you have a pill problem, the following questions might help you decide. 1. Has your doctor, spouse, or anyone else expressed concern about your use of medications? 2. Have you ever decided to stop taking pills only to find yourself taking them again contrary to your earlier decision? 3. Have you ever felt remorse or concern about taking pills? 4. Has your efficiency or ambition decreased since taking pills? 5. Have you established a supply for purse or pocket or to hide away in case of emergency? 6. Have you ever been treated by a physician or hospital for excessive use of pills or alcohol? 7. Have you changed doctors or drug stores for the purpose of maintaining your supply? 8. Have you received the same pill from 2 or more physicians or druggists at approximately the same time? 9. Have you ever been turned down for a refill? 10. Have you taken the same mind or mood-affecting medication for over a year only to find you still have the same symptoms? 11. Have you ever informed your physician as to which pill works best, at which dosage, and had him adjust the prescription to your recommendations? 12. Have you used a tranquilizer or a sleep medication for a period of months or years with no improvement in the problem? 13. Have you increased the dosage, strength, or frequency of your medication over the past months or years? 14. Is your medication quite important to you? That is, do you worry about refills long before running out? 15. Do you become annoyed or uncomfortable when others talk about your use of medications? 16. Have you or anyone else noticed a change of personality when you take your medication? 17. Have you ever taken your medication before you had the associated symptom? 18. Have you ever been embarrassed by your behavior when under the influence of your prescription drug? 19. Do you ever sneak or hide your pills? 20. Do you find it impossible to stop or to go for a prolonged period without your pills? If you've answered yes to a number of these questions, you might want to discuss this matter with your sponsor and with AA members who have had experience with prescription pill addiction. Not all mind or mood-affecting medications are equally dangerous for recovering alcoholics. Listed below are several categories of medications with brief comments regarding the relative dangers of each. Minor tranquilizers. Trade names include Librium, Valium, Ativan, Transine, Xanax, and many others. Don't be deceived by the word minor. Minor refers to the fact that these drugs are effective in treating relatively minor psychiatric symptoms such as simple nervousness, agitation, or alcohol withdrawal. Alcohol is a minor tranquilizer, and taking any of these drugs can have an effect similar to drinking alcohol. Symptoms of addiction to these drugs are remarkably similar to those of addiction to alcohol. However, they appear later, persist longer, and are more difficult to overcome. For this reason, patients addicted to both alcohol and prescription pills may go through a double withdrawal, first from alcohol and then from tranquilizers. Major tranquilizers. Trade names include Thorazine, Stelazine, Haldol, Melaril, and many others. These drugs are useful in treating psychoses, major psychiatric conditions such as schizophrenia, paranoia, and the hallucinations of delirium tremens. Because they are less addicting and the conditions for which they are prescribed are more serious, patients should rely on their physician's advice regarding their use. Antidepressants. Examples include Ascendin, Deseril, Elavil, Ludiamil, Tofranil, and more recently, Prozac, Zoloft, Paxil, Effexor, and related chemicals. At present, these drugs don't appear to be addicting, and they are often quite beneficial in true depression. On the other hand, it doesn't make sense to medicate the depression of early recovery and the minor bouts of depression which are a part of everyday life. These get better on their own without medical intervention. Likewise, a few years into recovery, some alcoholics develop the blahs, a sort of, "is that all there is" feeling. They wonder if maybe they're in a depression and should see a therapist, or they think maybe they need medication, or maybe they have some sort of chemical imbalance. Many times, dramatic improvement in this condition follows a redoing of each of the 12 steps, especially when the negative feelings are treated as a defect of character in the 6th and 7th steps. Regarding Prozac, you can learn more than you need to know about its beneficial effects by reading Kramer's highly advertised Listening to Prozac. To learn about its dangers, read Talking Back to Prozac by Breggin, Breggin, who also wrote Toxic Psychiatry. Sleeping pills. Examples include Halcion, Dalmane, Restoril, Noludar, Nembutal, and Seconal. These medications are as dangerous or more dangerous than the minor tranquilizers. Alcoholics who use them put their sobriety at considerable risk. The risk extends to the use of non-prescription medications, such as Sominex, asking a physician for something mild or considering a pill safe simply because it is new. These are merely ways of continuing to seek chemical answers to life's living problems. And sleep is, for many of us, one of life's living problems. Temporary difficulties in sleeping are common after years of dependence on the sedative drug alcohol. Unmedicated, the sleep pattern returns to normal. Cough preparations. When you pick up a bottle of cough syrup, read the label. According to law, if it contains alcohol, the label will state the amount. In sharp contrast, until recently, the law forbade the listing of the alcohol content on a bottle of beer. Some cough preparations contain codeine. Others contain antihistamines, which can have a sedative effect and cause sleepiness. Ornicol capsules contain no alcohol, codeine, or antihistamines, and are available without a prescription. Alcohol-free liquid cough preparations not requiring a prescription include Ornicol syrup and syrup of triaminical. Your pharmacist can recommend many others, and doctors will prescribe an alcohol-free cough preparation if requested. Syrup of Hycamine or Hycodan, Tacionex suspension, and Actifed C expectorant are examples. Emergencies and post-operative pain. When the medical situation demands their use, recovering alcoholic patients can safely take sedative and pain-relieving medications such as Demerol and morphine in their customary dosages. However, these drugs should be discontinued as soon as practical. The longer they are continued, the more likely the alcoholic is to get into trouble. Obviously, recovering alcoholics who are taking narcotic drugs for whatever reason should intensify their recovery program. They can do this, for example, by increasing the number of AA meetings they attend, by encouraging visits by AA members, by openly discussing their fears and their use of medications, by frequent reading of the Big Book, and by listening to audio tapes of AA meetings. Pain medications. Aspirin, Tylenol, Advil, Motrin, and all the non-steroidal anti-inflammatory agents used for arthritic and similar pain are non-addicting and are, in that sense, safe for alcoholics. Darvon and codeine are different in that alcoholics do become addicted to them. Don't concern yourself about Novocaine or other local anesthetics used by your dentist while in his or her office. However, be careful when leaving. Dentists often send patients home with a fairly large supply of codeine or Vicodin.
This is the end of Side 1. Stop the tape now, turn it over, and begin listening to Side 2.
For chronic pain, become familiar with the many effective, non-chemical methods of treating pain. A good place to start would be Dr. Norman J. Marcus's new book, Freedom from Chronic Pain, or Charles Stacey's The Fight Against Pain. If you prefer a video, start with Bill Moyer's video series, Healing and the Mind. Pep pills. Pep pills and appetite suppressants such as Dexamyl, Desoxin, Ionamine, Pandamin, and all the amphetamines are quite addictive and should be avoided by all alcoholics and non-alcoholics. Anticonvulsants. Examples include Dilantin, Misoline, and Tegretol. They are non-addicting and affect alcoholics no differently than non-alcoholics. Even the phenobarbital in Dilantin with phenobarbital doesn't seem to cause significant trouble. Lithium. Lithium is singularly effective in helping to control the excessive mood swings of manic depressive illness. It particularly suppresses the upward swings, the ones that make the patient feel so good. Perhaps for this reason, patients often stop taking their lithium. Lithium has a variety of important side effects when not taken exactly as prescribed. The exact dosage depends on periodic blood tests to determine the blood level of the drug. When doctors first discovered the effect of lithium on manic depressive illness, they expressed considerable surprise and jubilation, and they predicted that it would soon become the drug of choice in the treatment of alcoholism. Such has not been the case. Not every alcoholic showing swings of mood has manic depressive illness. Besides, in time, the serenity of a good recovery program tends to smooth out many of these emotional ups and downs. Newer antidepressants and tranquilizers. Although I have had no direct clinical experience with these newer antidepressants and tranquilizers, I understand they can be quite effective in the treatment of true depression. As to whether or not they are habit-forming or have other undesirable long-term side effects, medications routinely enter the market with a good record in this regard. Reports of these problems don't appear until much later, not until after patients have become addicted and developed long-term side effects, and alcoholics have gotten drunk. Patients recovering from alcohol or other chemical dependencies face an additional task when their doctor prescribes a medication to control their emotions. By doing this, the doctor implicitly gives credibility to one of the patient's most troublesome beliefs, the belief that if things get bad enough, a person can always turn to a chemical answer to life's problems. Over time, the patient relies more and more on the doctor and the pill than on the personal recovery program. The distinction between tranquility and serenity becomes blurred. Tranquility of this sort always comes in a bottle and is never more than a cheap imitation of serenity. What I wish doctors believed. Alcoholics and other chemically dependent patients would have fewer problems with prescription drugs if all doctors believed as I do. An alcoholic can't consistently stop drinking after the first drink, and can't on his own comfortably and permanently abstain from drinking. That, I believe, is the disease of alcoholism. As I see it, the underlying cause of alcoholism is an alteration in the chemistry of the brain in a susceptible individual. Just as a patient allergic to penicillin cannot safely use antibiotics of the penicillin type, and a patient allergic to aspirin cannot safely use aspirin-like pain medications, so too a patient allergic to alcohol cannot safely use many of the common mood-affecting medications. Furthermore, this abnormal response to alcohol and to mood-affecting medications is shared by patients with a history of addiction to cocaine, narcotics, prescription pills, and other chemicals. Like alcoholics, their recovery depends on total permanent abstinence from alcohol and mood-affecting chemicals. And like alcoholics, their continuing recovery depends on involvement with others with the same problem in a mutual recovery program, such as Alcoholics Anonymous, Cocaine Anonymous, Narcotics Anonymous, Pills Anonymous, or other anonymous programs. I believe physicians can be of service to their alcoholic, pill-addicted, and other addicted patients by establishing the diagnosis or by accepting the diagnosis when it has already been accepted by the patient. He can help further by encouraging lifelong association with an appropriate recovery group and by consistently refusing to prescribe chemicals conducive to a return to drinking or to the abuse of medications. What to tell your physician? When alcoholics get into trouble as a result of taking prescription pills, they often complain, "I told him I was an alcoholic and he gave them to me anyway." The problem, as mentioned earlier, is that doctors don't always understand what we mean when we say we are alcoholic. Here is an example of wording a doctor would probably understand. I am recovering from alcoholism, or chemical dependency, and am anxious to refrain from the use of prescription medications which might result in a relapse. I understand the dangerous drugs to be those that affect the mind or mood, such as minor tranquilizers, sedatives, sleeping pills, amphetamines, and narcotics. Please consider me sensitive or allergic or as reacting abnormally to these drugs and note this in my chart. I wish to openly discuss with you any situation which you believe calls for their use. Thank you sincerely for your cooperation in this matter and for your ongoing concern for my welfare. Conclusion. As practicing alcoholics, we couldn't control how much we drank once we started, and we couldn't keep from starting. In sobriety, with the help of a higher power and the steps of AA, we transcend that problem. This same combination of steps and higher power allows us to live comfortably with the fact that sometimes we must take a prescribed medication. It also gives us a plan of action whereby we avoid the use of medications to control our emotions. In both situations, acceptance is the answer. We have learned to depend on spiritual rather than chemical answers to our living problems. Ultimately, we are grateful not to have to rely on alcohol and pills, as do so many people who lack a higher power and a 12-step program. Addendum B. Sleeping without pills. Sleeping. Insomnia. Insomniacs recovering from alcoholism are lucky. They already know from personal experience that recovery from alcoholism depends on a willingness to surrender. In like manner, recovery from insomnia is another example of surrendering to win. In AA, by surrendering to our powerlessness, we transcend our drinking problem. Then, those of us who suffer from insomnia discover that the power that keeps us sober during the day also works at night. Alcoholics have sleep problems because alcohol and sleeping pills suppress the REM, rapid eye movement, sleep pattern. This doesn't return to normal immediately in sobriety. Indeed, it may never do so if periodically disturbed by the use of alcohol or sleep medications. Newcomers in recovery are well advised to have a medical checkup, but to decline offers of prescriptions for sleeping pills. Living consists of problems, and for many of us, sleeping is one of those problems. Our first inclination is to take something to help us sleep. We are headed for trouble if we do, because that intensifies the problem. The better the chemical works, the less likely we are to sleep well thereafter without it. With continued use, more of the chemical is required to get the same effect, and the effect lasts for progressively shorter periods of time. Eventually, other chemicals must be added to counteract the side effects which develop from the excessive use of the first chemical. Working on the problem. Insomnia is a nuisance, not a disease. It should not be medicated. Besides, few things stimulate insomnia more than a decision to work on it. Insomnia always accepts the challenge. I must have been born with insomnia. I fought it all through my pre-AA life and early sobriety. In the late 1930s, while attending pharmacy school, I discovered what I thought would be the answer to my sleep problem. After putting in a hard day's work at school, working in the family drugstore all evening, and then studying into the wee hours of the night, I found that a couple beers allowed me to jump in bed, sleep real fast, and wake up smart. Better living through chemistry soon became my way of life. For the next 30 years, I literally worked on the problem of relaxing. I did everything I could think of and took every drug I could find that might force me to sleep. The harder I worked on the problem, the worse it got. And the worse it got, the harder I worked on it. Toward the end, in addition to alcohol and pills, it took 2 intravenous injections of barbiturates administered surreptitiously in the garage to get me through the night. Even so, it wasn't a particularly restful sleep. Certainly what I was doing couldn't be described as social sleeping. Today I realize that I thought of sleep as a period of unconsciousness preceded by a period of increasing drowsiness. Furthermore, I had been misinformed that everyone needed at least 8 hours sleep every night, and I set out to get my full quota. New ideas. The military services have conducted experiments to determine the minimum requirements for sleep and the maximum length of time a man can be forcibly kept awake. These studies have shown that, while periods of relaxation are quite important, a total lack of consciousness is not necessary. On the other hand, even using strong persuasion, it is impossible to keep the mind awake once it decides to go to sleep. The mind will sleep, even if for only brief periods of time, no matter what one does to keep it awake. These brief mini-sleeps are of extreme importance to those of us with sleep problems. They form the basis for the statement that no one ever died from lack of sleep. It also explains why it is impossible to commit suicide by staying awake, as opposed to taking an overdose of pills and sleeping oneself to death. Even those who can sleep any time they want can't really control their state of consciousness. They can't lose and regain consciousness at will. They can do things conducive to losing consciousness or waking up, but they can't literally make it happen. Unconsciousness. Therein lies the answer to our sleep problem. We must stop demanding unconsciousness. We must stop trying to manage something over which we are powerless. Our only recourse is to relax, stop struggling, and let go. We must learn to turn over to the care of God not only our will and our lives, but also our sleep. After we do that, how much sleep we get is no longer our concern. It's His. And if we should die from lack of sleep, it's His fault. Turning over a sleep problem to God is like turning over any other problem. If we continue to have any idea as to how He ought to handle it, we haven't really turned it over. Surrender comes first, giving up all opinions, notions, and beliefs as to our nocturnal needs and wants. Then relaxation. Then acceptance, grateful acceptance of whatever God sends us throughout the night. How to sleep without pills. Because I haven't yet perfected any part of my recovery program, I still sleep poorly at times. When this happens, I don't talk about it or allow it to affect my mood or activities the next day. When I tell someone I am tired, I give them a totally useless piece of information. They can't help me. And even more important, I admit to them and to myself that a simple sleep problem has the power to control my day and my life. Then, to regain control of my life, I insist on more sleep, and I attempt to get it by trying to control something over which I am powerless. Worrying about whether or not I get enough sleep is an old way of thinking which I have had to give up. The title of one of Terry Cole Whitaker's books is, "What You Think of Me Is None of My Business." I prefer to think of it as, "Whether or not I get enough sleep is none of my business." On the other hand, we can't ask God to help us sleep if we don't cooperate. Many alcoholics complain of restless nights while they continue to smoke cigarettes and drink beverages loaded with caffeine and sugar. This doesn't matter, they insist, because they have no trouble getting to sleep. Their problem is staying asleep. My experience tells me we sleep better after we give ourselves 4 to 6 or more weeks without caffeine and excessive sugar, and preferably also without nicotine or chocolate. One of the many techniques for relaxing to get to sleep is known as progressive muscle relaxation. To practice it, lie quietly and make a tight fist to see how contracted muscles feel. And then relax your fist to see how relaxation feels. Repeat this procedure until you are familiar with the feeling of relaxation. Now, eliminate the contraction phase and relax the toes on one foot and then on the other. Next, one foot and ankle, then the other. Then each calf and each thigh. Slowly progress upward through all the muscles of the body, including the face and scalp. Repeat this relaxing procedure until sleep intervenes. A similar method focuses attention on the joints rather than the muscles. Lie very still. Focus your attention on first one toe and then another. Ask yourself the exact location of each toe in relation to the other toes and the rest of my body. Do not move the toe to answer the question, is it bent or straight? What is it touching? After carefully and thoroughly checking each toe, check one ankle joint, then the other, then the knees, the hips, the spine, and eventually every joint in the body. If still awake, count backwards from 500 by threes. Allow yourself to think of nothing else, and start over every time you get lost or begin to fall asleep. If you dislike arithmetic as much as I do, your mind will rebel and shut itself off. On other occasions, you can count backwards from 500 by ones, carefully visualizing every number. 499, 498, 497, 496, and so forth. As I see it, the trick for me in all these techniques is to assume the role of choir master and get all the voices in my head to focus on one single bland sentence or thought. In time, the voices quiet down and disappear. I open my eyes and find it suddenly much later than it was. Or, to state it differently, while thinking a thought, I lose consciousness and wake up thinking the same thought without realizing I'd been asleep. These mini-sleeps are extremely important because they add up during the night when I lie quietly and allow them to happen. But while anticipating and doing everything I can to encourage them, I try not to make them happen. Although these Many sleeps recur again and again and again. I'm still pleasantly surprised and grateful every time they happen. During the night, I never check on the time. Lacking any middle-of-the-night appointments, my only reason for watching the time would be to decide how tired to be the next day. Merely glancing at the clock aggravates my problem by taking my mind off the answer and refocusing it on the problem. Add the program. The techniques mentioned so far can be used by non-alcoholics as well as alcoholics, but for me, the real answers to a sleep problem come from the AA program. If I keep the big book at my bedside and read it when I can't sleep, I can't lose. I'll either become an expert on the big book, or on sleeping, or on both. I find particularly appropriate the book's strong admonition, expressed twice, that we cease fighting anything or anybody. I understand this to include fighting sleep and the nocturnal voices in my head. During the day, I often relax, close my eyes, and enjoy a short, refreshing cat nap. At night, I read until I find myself rereading the same paragraphs. After turning out the light, I keep my mind focused on a single, simple thought such as, "If God be with me, who can be against me?" Or I recite and meditate on the meaning of the Serenity Prayer, or the Third Step Prayer, or the Seventh Step Prayer. At other times I recite and dwell on the precise meaning of the 12 steps. Formerly, when all else failed, I played an AA tape. Currently, my sleep program consists of 1. Allowing my muscles and joints to relax. 2. Being completely satisfied with and optimistic about mini-sleeps with no demands for drowsiness. 3. Breathing diaphragmatically, also known as abdominally. The abdomen belly swells with each inhalation and contracts with each exhalation. The incoming air flows downward rather than upward. This is an excellent way to breathe when tense or nervous, or when about to speak in public, or at any time. 4. Allowing my mind to think about nothing but how I am breathing and the very important fact that God resides deep within me. 5. Persisting in this program even when it seems obvious that it isn't working. As a result of this program, most of my nights are now both physically relaxing and spiritually stimulating. Conclusion. Faced with the problem of alcoholism, I fought it as long and as hard as I could. When I could fight no longer, I surrendered and gave the problem to my higher power. At that point, I won. I became comfortable. The problem ceased to be a problem, and I am now spiritually and emotionally stronger for having surrendered to my drinking problem. My sleep problem shares a similar history. I had to let go of it. I had to give it to my higher power. Then I had to pray, not for sleep, but for the willingness to lie awake, waiting for him to decide whether or not I lost consciousness. This combination of willingness to lie awake and be satisfied with many sleeps, plus focused, single-thought thinking, provides me with all the sleep I need. And in addition, as with my alcoholism, I am a spiritually and emotionally stronger person for having had the problem and for having surrendered to it. Afterward. Well, it's been a long journey. I have a sense of accomplishment at having brought the project this far. I've often wondered if putting this book together has been an ego trip for me, but every time I decided to give it up, friends have urged me to keep going. Furthermore, I have repeatedly recited a modified version of the Third Step Prayer, in which I offer myself and the manuscript to God to do with as He wishes. It has been, and it continues to be, entirely up to Him as to what happens next. I've benefited a great deal from writing this, and I hope someone benefits from reading it.
More to Quitting Drinking Than Quitting Drinking by Dr. Paul O. was read by Father Tom W. Audio was produced and edited at Inner Light Production Studios by Owen Howson. For a free catalog of tapes on recovery, call Inner Light Productions toll-free number 1-800-537-6767. You may visit our website at www.inlight.com. That's www.inlight.com.